Thanks. Good afternoon. Thank you for the opportunity to present today. I'm going to take things in a little bit of a different direction from the other prior excellent presentations. I'd like to thank the New York and New Jersey ERC pilot program for providing me the funding to be able to do this project. So work-related musculoskeletal pain occurs in the setting of overexertion, working in non-neutral postures, and forceful repetitive motions. And although surgeons are subject to similar exposures as in other fields, the rules and regulations that have been widely accepted for injury prevention in other industries, such as manufacturing, have been widely ignored in surgery. Surgery represents a unique occupation for several reasons, including long duration of work in static positions with limited or no breaks, awkward neck postures from monitor positions, variations in tool placements in different cases, and different tools used due to the anatomical variation between patients and between surgeons, incompatibilities in body height and habitus among members of the surgical team, and constraints in design for non-disposable instruments as a result of regulations on materials and safe cleaning. There has been limited research evaluating the prevalence of occupational injury in surgeons. The largest study to date was a meta-analysis of 5,800 surgeons that included 21 studies, and there was significant heterogeneity in the study survey instruments that were used, questions asked, and types of surgeons that were interviewed. The study did demonstrate, though, that up to 80% of surgeons had significant pain, but only 12% modified their practice or took a leave of absence. Surgeons have previously reported both low awareness of occupational injury and minimal formal ergonomics training as well, which has primarily been provided as informal intraoperative directives rather than formal education. Given the high rate of work-related pain, it's unfortunate that awareness and education remain low. Surgeons are also uniquely pressured not to report injuries, given that time off or reduced duty may result in reduced practice and lost revenue to the physician and the institution. However, surgeon injury may have adverse effects on the quality of care that's provided and result in reduced morale, self-medication, and other hazards to safe practice. Nationwide, there has been a massive increase in emphasis on trainee wellness among residents, and among surgical trainees, burnout rates of up to 70% have been demonstrated. Burnout has been linked to lower professionalism, increased medical errors, worse patient outcomes, and higher physician distress, including suicidal ideation. The primary focus of the conversation, both nationally and locally, has been on the relationship between emotional well-being and burnout. However, work-related musculoskeletal pain has also been associated with increasing reports of fatigue, psychosocial distress, depression, stress, and sleep disruption. And as such, this problem represents an important area for intervention, as improved physical wellness may have an important role in emotional wellness. The prevalence of work-related musculoskeletal pain among surgical trainees is unknown, but likely to be high. Furthermore, the association between work-related musculoskeletal pain and the broader aspects of trainee wellness and functional ability at work is not known. However, the limited data available suggests that this is likely an important problem. And as such, the objectives of this study were to determine the prevalence of work-related musculoskeletal pain among surgical trainees, to determine whether work-related musculoskeletal pain is associated with adverse psychosocial consequences, to characterize current trainee understanding of work-related musculoskeletal pain prevention and ergonomics, as well as to assess trainee interest in further education in ergonomics and prevention of work-related musculoskeletal pain. In this study, we administered a survey to surgical residents at the Mount Sinai Hospital Center. Trainees from the fields listed on the screen were contacted by email to participate in an online survey. They received a $10 gift certificate in exchange for participation. Weekly reminders were sent over the course of the study period. A survey had been created that was adapted from validated instruments, including the standardized Nordic questionnaire to determine location and type of pain that was experienced, as well as the SF-36 to assess overall quality of life and wellness. And then other related questions pertaining to demographics, as well as time spent in the hospital, were also included. The characteristics and SF-36 scores were compared between trainees with and without work-related musculoskeletal pain. We had a 68% response rate amongst the residents that were surveyed. 40% were female, 44% were in their earlier training years, PGY 1 or 2, and 56% were PGY 3 or above. The median age among participants was 29, BMI was 23, and the median hours worked per week was 80 with an interquartile range of 70 to 80, and median hours in the OR of 30 with an interquartile range of 15.5 to 40. 76% of respondents reported pain within the last 12 months. 66% reported pain due to table height. However, only 33% of respondents, interestingly, reported feeling very or extremely comfortable asking their attending to make adjustments either to table height or to monitor placements in order to improve their own personal ergonomics. In this figure, you can see the location of the pain that was experienced, and neck and back pain was most frequently reported. Additionally, the most frequently reported symptoms were aches and pain, and 6% of respondents reported receiving treatment for their symptoms. In this figure, the SF36 scores in the included domains in the survey were compared between respondents with and without work-related musculoskeletal pain. What you can see here is on univariate analysis, there was a worse score for those with work-related musculoskeletal pain for the domains of role limitations due to physical health and emotional health. After adjusting for other factors that were significant on univariate analysis, only role limitations due to emotional health remained significant after adjusting for both sex and training year, suggesting that there is some association between work-related musculoskeletal pain and emotional health. When asked about education on ergonomics, most trainees, 73%, reported never receiving any ergonomics training, and they were not aware of any ergonomics guidelines for the operating room. However, 95% believe that ergonomics education is important. This study has several limitations. There's some heterogeneity in terms of the specialties that we included that can result potentially in underestimating the prevalence and risk factors for work-related musculoskeletal pain. For example, ophthalmology is very different than general surgery, and therefore factors such as hours in the OR really differ, as some fields do have more time spent doing procedures in the clinic versus the operating room, and there are differences with respect to monitor use as well as foot pedal use and procedures performed either sitting or standing, which could impact this as well. Additionally, there may be an element of social desirability bias, meaning that surgical residents may feel pressured to underreport physical or emotional stress in the survey. I wanted to just conclude by kind of including this as the current status of ergonomics education in general surgery, which is my field. There's significant room for improvement in the current education. This is from our formal educational module SCORE, which is the formal national educational platform for surgical residents. And basically what you can see is that across all of the modules that are included, the word ergonomics only shows up once, and it shows up under the module for robotic surgery under advantages and disadvantages, and it just says the surgeon console is designed to improve surgeon ergonomics, and that's the extent of the current mandated understanding of ergonomics in general surgery education right now. So in conclusion, work-related musculoskeletal pain is common among surgical trainees. Surgical trainees have a low awareness of mechanisms for prevention of work-related musculoskeletal pain. Work-related musculoskeletal pain may be associated with worse emotional health among surgical trainees, and therefore increasing access to ergonomics training and work-related musculoskeletal pain prevention may improve well-being in surgical trainees. I'd like to thank my collaborators, Dr. Meyer and Dr. Divino, as well as, again, thank the ERC for allowing me to do this project, and I'll welcome any questions, or if anyone has any ideas on how to better intervene, I would be happy to welcome any opportunities to collaborate.
Thank you, Tamar. I don't see any questions in the chat box. Okay, I see Joanne, please unmute yourself.
I'm actually in the ergonomics and biomechanics program at NYU and used to work for surgeons. So this is really interesting. My question is if there were specific interventions that you were trying to at least hint at. It is interesting that the question about ergonomics came up in the robotics part of the survey, but are there certain kinds of, from your vantage point, are there certain things that could be put in, like with the tables or with, I guess, some of the hand tools? Are there any things that you're kind of endorsing?
So I think that's a great question. I think there are a few potential areas for intervention. I think, I know that there have been some studies, using like electromyography and things to assess the impact of various, surgical positions and things to determine what's optimal or whether robotics is better than traditional laparoscopy. And I think, that data is inconclusive and shows some, advantages to either one, but I think, trainees specifically are uniquely vulnerable in that, as I showed in the data, only 33% felt comfortable asking their attending to adjust the monitor or to, adjust the table height. And the majority of them, 75% or so, didn't even know about, occupational injury or any ergonomics guidelines. So I think, one thing that I would like to do, which we tried to do last year, but I was hoping to find maybe someone who, is more, trained in biomechanics, since it was just, from my department, but really to kind of do an educational session explaining on optimal, because there is some literature on this, on how to optimally hold the instrument, for example, so that you're not really straining your hand, which does happen a lot during laparoscopy when you're kind of straining in awkward positions. Where should the monitor optimally be placed? And so I think, I think that these kinds of things would be very important to be able to include more formally. And so that robotics kind of thing that I was showing at the very end, that's from our national curriculum in terms of what we're expected to know about ergonomics, and it's not much. So I think even just starting with fundamentals, like the appropriate table height is supposed to be here, and then so as the trainee, let's say the table is way too, high or low for you, you can at least try to adjust your own position, and maybe guide the attending as well. But I think, trainees are a little bit unique in that sense, in that the, attending surgeon is still dictating a lot of the kind of decisions regarding monitor placement and things like that in the operating room. But I think if anyone has any sort of biomechanical kind of knowledge on how to properly use things and would like to do any sort of educational session, we would welcome it very much.
Okay, Candace? We will take questions from Candace and Mary Grace. All other questions will be forwarded.
Okay.
Candace?
Great job, Tamar. Do you think that there is potentially a role for employee health services as kind of the outside, people to potentially provide additional training and support for surgical trainees in the Sinai system? Because, I was not that long ago, I know what it's like to be a resident. I'm sure there's a lot of pressure that surgical trainees may feel. I'm just wondering, do you think, there's a role for employee health to say, provide, ergonomics training or counseling, so that it's somebody from the outside saying, hey, this is very important for the resident's safety, and maybe they may feel more comfortable?
I think that would be great. I think that what we're lacking currently is, even, for example, operating room nurses or nurses on the floor are taught how to properly move patients around, for example. But in the operating room, we're also transporting the patient onto and off of the bed and things like that. And we don't get any training in that. And sometimes you're doing very heavy lifting, probably inappropriately, for example. I think otherwise, if there is somebody in employee health or someone that could further counsel us on kind of, any sort of ergonomic things that they know unique to the operating room, I think that would be really important, because, the session that we tried to do last year was really one of our surgeons that kind of was just, was probably more, as I said, kind of informal, anecdotal discussion, as that study also showed. That was probably the predominant kind of, education that's provided, rather than formal experts that can sort of give us concrete, advice. So we would welcome that if you think that you could provide something like that.
Okay, thank you. One more question from Mary Grace.
Sorry, I don't have any questions. I just thought it was a great presentation. Being a former surgical trainee, I echo all the sentiments of Tamar, and I do think residents are in a compromised position. There's a power authority discrepancy between attendings and trainees, where you are in high demand. It's a high demand, low control situation you are in as a surgical resident, in terms of the four corners of the Karasik model, the demand control model. And obviously I think that's a great solution. Using employee health and maybe OSHA and their ergonomic courses could in some way be prioritized for surgeons.
Thank you.
Okay, thank you. Thank you, Tamar.